Thank you so much for your kind introduction. These are my conflicts of interest. And dear colleagues, I would like to draw first your attention to the world's population in general. That is, the population is aging. There is a global trend. In 2024, 800 million people were 65 years of older. But in 2074, that will double. And that means that 1 in 5 people in 2074 will be more than 65 years. And when we look at the people at 80 years, then actually the population of people more than 80 years will triple. Healthcare will increase tremendously in the area of care for elderly people, and especially also in the field of comorbidities, and especially our comorbidity that is actually metabolic health. There will in the general population be an enormous increase. And what is actually then the situation in psoriasis and elderly? We know that in people younger than 70 years, that hypertension, dyslipidemia, diabetes, and MACE are increased as compared to non-psoriatic persons. But in people more than 70 years of age and having psoriasis, we see that it is more normal there to have actually an abnormality in metabolic health than to be normal in this respect. And that means that when we are dealing with patients with psoriasis, in elderly patients with psoriasis, that we should pay attention to metabolic health. In contrast to the common belief, where in the past I have learned, well, when people are elderly, then the quality of life issue is not so much anymore an issue for patients with psoriasis. And on the contrary, actually in people who are elderly, actually the issues regarding quality of life are even more expressed. And what is it that actually is so important to pay attention to? That is, doctor, I would like to sleep better, or then to be less dependent on doctors and clinical visits. It's come to you as taking me a lot of effort. To have fewer side effects and to have confidence in the therapy. That are issues which are very important. So in elderly patients, we have to strive for optimal treatment. We have to be ambitious. And let's now go to the treatments. Topicals, phototherapy, classical systemics first. Well, phototherapy and topical therapy can be administered in elderly people, but might be too stressful for some of them. And some of them is important. For treatment of elderly patients is personalized care. You have to know your patients well, what they can do, and what the load can be for a patient with respect to the treatment. Acetylene can be administered in elderly patients on the same dosing schedule as younger patients. However, serum lipids and liver enzymes should be monitored. Cyclosporin should be used with caution in patients with possible renal impairment and hypertension. Look at the comorbidities and do personalized care. Methotrexate requires some precaution in elderly people. Methotrexate is a time-honored treatment, but it is important that you adhere well to the guidelines in order to provide a safe treatment. And in elderly, we have to pay attention to the following. There can be predisposing factors for bone marrow suppression. That's concomitant use of NSAIDs, immunosuppressants, liver disease, underlying renal function impairment, low albumin, and dehydration. And it's important to pay attention to that. And further, the serum creatinine, a marker to assess renal function, This is important renal function, for we know that the kidney is important in the elimination of methotrexate for the body. And when you have an impaired kidney functioning, actually your methotrexate levels may go up. Older patients with less muscle mass may have low creatinine levels, leading to overestimating their true renal function. And now to biologics and small molecules. When considering biologics in elderly, the available literature on safety and efficacy supports the use of these agents in this population. Be prudent in screening before initiating biologics and monitoring patients more closely, as elderly have a higher baseline burden of comorbid condition. Well, deucravacitinib, there's limited experience so far in elderly and has no warnings regarding elderly. And apremilast, take notice of diarrhea, nausea, and vomiting, which can be a problem in elderly people. But what do we see? We actually see that with aging, with every year's increase in age, the chance that you get a biologic is decreasing. So in real practice, actually, dermatologists are reluctant, actually, to prescribe biologics. And that's a shame for reason that elderly people need adequate treatment. What's the evidence available? A systematic literature review has been done to examine the safety and efficacy of biologic agents approved for plaque psoriasis in elderly. 18 articles met the screening criteria, but actually this work was some time ago. So the biologics studied were infliximab, etanercept, adalimumab, and secukinumab, and ustekinumab. Across all biologic classes, efficacy for biologics between younger and adult patients and elderly patients was similar. And then adverse events and infections occurred at a similar frequency between both groups. However, serious adverse events and discontinuations due to adverse events were more common in elderly. However, of course, during the preparation of this talk, I looked to the original article, and actually these serious adverse events were all over the place and had not the typical distribution of adverse effects where you would think about the biologics. And therefore also the authors support the use of these agents in this population. There's a very nice study, a small study, on the efficacy and safety of IL-17 and IL-23 inhibitors in elderly people with plaque psoriasis. It is a retrospective study. It's a somewhat small study, 128 patients. And at week 52, the improvement rates were similar comparing younger and adult patients. So for efficacy, no difference between older and younger. Infections were the most frequently observed adverse events in both groups, and notably urinary tract infections were slightly more common among older patients, but I would be surprised when that would not be the outcome of that study, for urinary tract infections in elderly people are more frequent. Although no serious adverse effects leading to discontinuation were observed among patients aged more than 65 years, 2 individuals younger than 65 discontinued treatment. Real-world safety efficacy biologics in elderly patients with psoriasis. This is a multi-center observational study in Japan. It's a somewhat larger analysis, and the outcome is the following. Treatment ending adverse events occurred in 15% and 11% of elderly and younger patients. No significant difference in the frequency of infectious diseases between young and old. Nevertheless, infectious diseases were more prevalent in elderly patients than in younger patients. And overall, the authors confirm the appropriateness of using biologics in elderly patients with regard to safety and efficacy. It's a short presentation, so I would like to come now to a summary. Firstly, keep in mind, comorbidities are very common in older patients with psoriasis, most notably arterial hypertension, dyslipidemia, diabetes, and MACE. We cannot go around that. And psoriasis is an independent risk factor here, and we see that in elderly patients. Psoriasis may also impose a greater quality of life burden in elderly patients, but they are less likely to receive biologic treatment for psoriasis than younger patients, and that's a shame. We should change that. Management of psoriasis in elderly patients influenced by multiple factors: comorbidities, polypharmacy, adverse events, risk factors, and self-care. And therefore, personalized care is so important in elderly patients. And the approach to that is real-world evidence studies. Not so much a well-designed, neat clinical trial, but we need real-world evidence of the registries to inform us continuously on actually the care for elderly patients where a personalized approach is important. With respect to the treatment of elderly with biologics, efficacy and safety are comparable with younger patients. And awareness is needed of a higher baseline burden of comorbid conditions, and therefore, in our elderly patients with psoriasis, we have to monitor them well and treat them well and be ambitious. Thank you very much.
Thank you very much, Peter. Maybe time for one short question. Okay, I'll do it. So after listening to your presentation, so age, when thinking about prescribing a targeted drug, a biologic therapy, is a restriction or maybe is an incentive to do it? So it's a positive effect to do it.
Sorry, I didn't hear quite well.
Yes, so age, when you intend to prescribe a biologic therapy, yes, age is a barrier or maybe is an incentive. So to have an older patient incentivate to prescribe biologic therapy.
Yes,
before.
My personal opinion here is the following, that we have to be upfront here. And there is actually no evidence, but I should admit that the number of studies has to increase. We have to get more evidence, but the evidence so far does not give any restriction here with respect to the prescription of biologics in elderly. And when I look to the different biologics available, I would like to especially look at the anti-IL-70s, but even more to the anti-IL-23s as a very safe approach actually in the management. But it is important before you start any therapy in elderly people to be aware of comorbidities. And that is not selective for biologics, it's for all the treatments.
Okay,
yes?
Thank you.